function can be categorized as stenosis or regurgitation. Aortic stenosis is a chronic condition, with patients remaining asymptomatic for decades while the valve gets progressively stenotic. When symptoms do develop, the most common ones are exertional dyspnea, syncope, and angina. AS is usually severe by the time patients become symptomatic. The causes of aortic stenosis are pretty straightforward. Younger patients, if you can count under 60 as young, with AS usually have a congenital bicuspid aortic valve. Patients presenting after age 60 usually just have age-related sclerocalcific changes of a normal aortic valve. Worldwide, however, the most common cause of aortic stenosis remains rheumatic heart disease. The three characteristic exam findings in severe aortic stenosis are a weak and slow-rising carotid pulse, a soft single S2 heart sound, and a crescendo-decrescendo systolic ejection murmur best heard at the right upper sternal border, radiating to the carotids. Echocardiography is the gold standard for diagnosis of aortic stenosis and also allows you to determine severity, most commonly done through measurement of the valve area. The number to remember here is 1. A valve area less than 1 square centimeter puts your patient in the severe category. Definitive treatment of aortic stenosis, as with aortic regurg, is surgical aortic valve replacement. In general, surgery is reserved for patients with severe AS and symptoms or other risk factors for poor outcomes. When it comes to aortic regurg, there are two different types of presentations: chronic aortic regurg, which progresses slowly over many years, and acute aortic regurg, which manifests acutely over hours to days. Patients with acute aortic regurg most commonly present in cardiogenic shock from conditions such as endocarditis, aortic dissection, and accidental or iatrogenic trauma to the aortic valve. Chronic aortic regurg, on the other hand, presents in a similar fashion as aortic stenosis, asymptomatic for many years before manifesting with exertional dyspnea, angina, or other symptoms of heart failure. In developed countries, the most common causes of chronic aortic regurg is aortic root dilation and congenital bicuspid aortic valve. Worldwide, however, the most common cause of chronic aortic regurg remains, you guessed it, rheumatic heart disease. The hallmark of chronic aortic regurg is a widened pulse pressure, which can then lead to a number of unique physical exam findings, such as bounding water hammer pulses, pistol shot sounds heard over the femoral arteries, head bobbing, and uvula pulsations. The characteristic murmur of chronic aortic regurg is a diastolic decrescendo murmur best heard at the left sternal border, increasing with afterload increasing maneuvers such as squatting and sustained hand grip. Once again, echo is the gold standard for diagnosis of aortic regurgitation, whether chronic or acute. This time, rather than the valve area, a regurgitant volume greater than 50% is how many physicians define severe aortic regurg. Treatment of chronic aortic regurg is similar to that of aortic stenosis. Aortic valve replacement remains the definitive therapy and should be performed in all systematic patients with severe aortic regurg. In the case of chronic aortic regurg, however, vasodilators such as ACE inhibitors, nifedipine, and hydralazine can be used to reduce wall stress on the left ventricle in non-surgical patients. That about does